Thank you for that beautiful prayer and good morning. I'm so grateful to have been invited to address you today. I've been asked to talk about what works in Indigenous suicide prevention, adopting and adapting evidence-based practice. Let me start with an introduction. My name is Joseph Guan, and I am an enrolled member of the Aani-Grovant tribal nation at Fort Belknap in Montana. I'm an academic psychologist who engages in research around Indigenous mental health. I have 4 goals for us today in the brief remarks that I'm able to offer. First, I want to present the rationale for evidence-based practice, just so everyone who's hearing understands kind of where this conversation starts. Then I want to review the evidence base for mainstream suicide interventions. Next, I'll describe the evidence base for Indigenous suicide interventions. And finally, I'll quickly reflect on strategies to reduce Indigenous suicide. And hopefully this will open up for the remainder of the webinar today. We're going to hear from a lot of great people talking about some of the detailed aspects of this work, more so than I will have time to do. So let me start then with presenting a rationale for evidence-based practice. Again, just so we're all clear about where this comes from. Why evidence-based practice in mental health services? Well, first of all, we need to recognize that the need for mental health treatments eclipses the availability. That is that scarce resources are made available for mental health, and we have to make tough decisions about how to allocate those scarce resources. Most workaday mental health interventions have not been rigorously evaluated in scientific terms. And that's in part because clinician practice deviates from the structured interventions that have been designed or developed for mental health problems. Of course, mental health providers believe that their interventions work best. This is based on their training and their personal and professional experience. And yet the beliefs in the effectiveness of their interventions can be mistaken. In fact, the psychologist Scott Lilienfeld and colleagues published this paper in which they identified 26 reasons why we can believe that a treatment works when it really doesn't. So there's lots of reasons to be cautious about a commonplace off the top of our head assumption that a treatment works. Indeed, some treatments have been shown to cause harm, which is to say that someone who invented this thought it was a good idea. People believed it worked, whether that's facilitated communication for people with autism spectrum disorders, or drug abuse resistance education, or critical incident stress debriefing for trauma. When the research caught up to these programs, they found that actually they made things worse for people, not better. And so evidence-based practice really emerges from this commitment to provide healthcare services that are maximally likely to help people and certainly not to harm them. How then are evidence-based practice, how is it developed in mental health services? First of all, just a brief definition, evidence-based practice in psychology has been defined as the combination of the best research evidence, client values and preferences for treatments and interventions, and clinician expertise in delivering treatments and interventions. Best research evidence implies that the development of evidence-based practice really starts as a research endeavor. In psychology, we talk about evidence-based practice using this phrase, empirically supported mental health treatments. These are interventions that first originate in tightly controlled efficacy trials to try to establish cause and effect between a treatment and its outcomes and its benefits. The challenge with these kinds of tightly controlled scientific controlled trials is that such studies are highly artificial. And so once you've got evidence that there might be a cause and effect between a treatment and a desired outcome, next you confirm that through replication of positive results across multiple studies. Not 1, not 2, not 3, you want as many studies as possible. But of course, most studies are not very extensively replicated. Of those that are, once you've got pretty solid evidence in these trials, tightly controlled trials, that there's cause and effect relationships of the kind you want, then you want to expand these to effectiveness trials, which means you translate it to workaday healthcare settings and evaluate it in real world conditions with real world clinicians working with regular patients. And the goal is to try to ensure that the effects generalize to outside of the tightly controlled trials to everyday work. The problem with this step is that often the effectiveness that was observed in the tightly controlled trials drops off a bit. Things can be less effective once they get messier in the real world. However, once you have all of this evidence of proven benefits for a given intervention across numerous studies, then that evidence can be incorporated into formal clinical practice guidelines. that are meant to tell the profession, here's what you should do based on the best available evidence. Of course, this requires large numbers of participants, not 20, not 200 even, maybe to 20,000 in some instances, in really high quality studies that are assessed for their risk of bias and have really good quality experimental controls. Once interventions are proven through this process, then they get rolled out to the real world through dissemination and implementation efforts. The challenge, of course, is getting clinicians who are already trained in doing what they do and believing that what they do works to accept something new or different or unfamiliar. And so training can be burdensome. So this is the rationale for evidence-based practice. I just want to make sure that we're all clear about what it implies in mental health treatment. Next, I want to spend a little bit of time talking about evidence-based suicide interventions. These are mainstream interventions. And let me say that there's a lot of systematic reviews that are relevant to our conversation today, but there's not time in this brief presentation to do that. So I've just selected two to try to highlight a couple things that are important for us to realize. The first is a systematic review and meta-analysis by Hofstra and colleagues that was published in 2020. This was a formal meta-analysis of 15 controlled studies appearing between 2011 and 2017 with a total of 29,000 participants focused on completed suicides as an outcome or attempted suicides as an outcome. Now, a meta-analysis is a statistical procedure for combining outcomes across multiple studies that you can pool it all together and get a better sense for what's going on. And in this case, they limited to controlled studies, studies that had a comparison group to see if the intervention in question worked better compared to some other group that didn't get that intervention. It focused on completed suicides, of which there were 62 in this 29,000 participants, and attempted suicides, of which there were over 1,000. Now, just briefly, in terms of findings, the findings are broken out for preventing completed suicides and for preventing attempted suicides. And the point here is that actually the findings are different depending on which outcome you study. So I've highlighted red setting. For preventing completed suicides, this analysis revealed that the psychiatric ward had the largest effect of preventing completed suicides. Next was the community level interventions, which also had a large effect. And then the emergency room and outpatient specialty mental health clinics where there were not significant results. That's a little bit different than what they found for preventing attempted suicides. If you look at the setting, again in red, it was the outpatient specialty mental health clinic that had the largest effect. Then the psychiatric ward had a moderate effect down to the community level and emergency room. In addition, they found that if you combined interventions, you were likely to have better outcomes. So combining interventions across different providers or different domains or different settings had increasing effects. If one intervention had a small effect, 2 interventions had a moderate effect, and 3 interventions had a large effect. So the implications, I think, of this systematic review and meta-analysis are the following. First, there was a small number of controlled studies. All they could find was 16. This is a huge mental health problem around the world, and there were only 16 studies that they could include to do meta-analysis. And in addition, they targeted completed or attempted suicide, but not suicidal ideation. Why? Because suicidal ideation seems like a pretty different phenomena. It's way more common than completed or attempted suicide. And so they thought the better outcomes were really sticking to completed or attempted suicide. Next, suicide interventions have different effects on different outcomes across different settings. In other words, these findings can be complex and subtle, and that's what this reveals. Finally, they recommend, tentatively at least, that multi-level approaches across different providers, domains, and settings be undertaken, although they acknowledge that further research is necessary. So that's one systematic review. The next one I wanted to review is appeared in the American Journal of Psychiatry by Mann and colleagues in 2021. This included 97 randomized controlled trials and 30 epidemiological studies published between 2005 and 2019, focused on suicide, attempted suicide, or suicidal ideation. It was a narrative review because meta-analysis was not possible given the diversity of studies, and it really assessed replicated effects and scalability of interventions. So I want to share with you these findings just so we all have a sense for what is considered evidence-based suicide intervention according to this review. First of all, they classified effective and scalable interventions. That means they were proven to work to a certain degree, and they were also able to be ramped up for broader adoption to reach more people. Educating primary care physicians in the diagnosis and treatment of depression, say using antidepressants, was one effective and scalable intervention. Another one was educating high school students about mental health. Means restrictions like firearm control, that sort of thing. Pre-discharge education and outreach following hospitalization or crisis is another one that's effective and scalable. They also identified effective but less scalable interventions. These were the psychotherapies, like cognitive behavioral therapy, dialectical behavioral therapy, effective but a little harder to build up because they require professional training and doctoral level clinicians or master's level clinicians and so on. Then they identified unproven but scalable and therefore promising interventions. These have been tried and tested. So far, the evidence does not support them, but maybe with additional studies, we might find evidence. So fast-acting medications like ketamine to reduce depression symptoms more quickly than antidepressants do, internet-based screening and treatment, and passive monitoring via smartphone, very promising because they could scale up, but so far the evidence does not support them. Finally, there were interventions that they labeled as ineffective that have been studied pretty well and just don't seem to work. And that includes educating gatekeepers about youth suicidal behavior. They noted many limitations of this space. Again, it's the most recent systematic review I found that overviews so much of this important work. Two, I'll just point out our lack of replication and that suicidal ideation is very often used as an outcome when probably it's not the best thing to be studying. Take-home points. There are forms of suicide intervention that work, thank goodness. Combining more than one intervention into multi-level approaches works even better. Example is the zero suicide model that I think we're going to hear a little bit more about today. But not all popular suicide interventions have been shown to work. The gatekeepers for youth is one example. Others, they just don't have enough evidence yet. Research evidence on suicide interventions is complex and evolving. And so keeping up to date is a challenge for everyone. These are the realities of the research world that we need to keep in mind. Let me next shift to talking about Indigenous suicide interventions. I'm going to do so with reference to two systematic reviews that my former postdoctoral student, Tony Pham, and a collection of really incredible Native doctoral candidates in psychology teamed together to produce. The first systematic review was of intervention outcomes associated with Indigenous suicide interventions. And we published this in SSM Mental Health. Our research question: what interventions work to prevent American Indian and Alaska Native suicide? We used very broad inclusion criteria to capture a wide range of intervention outcome studies. We didn't want to exclude anything. We wanted to over-include, not exclude. By that process, we identified 28 studies with 23 unique interventions that were published between 1976 and 2020. These studies used direct measures of suicidal behavior, like suicide attempt and suicide ideation, that was 11 of them, or indirect measures of proxy variables that are associated with suicide, like hopelessness or alcohol abuse. That was the bulk of these studies, 26. This was a narrative review because of diversity across these studies. Meta-analysis was not possible. It's a quite impressive corpus, especially given the challenges, as we all know, of Indigenous community research. And many of the researchers who produced these studies are involved in today's workshop. You're going to be hearing from them later today. The major finding, really, in terms of our research question, was that the designs of these studies preclude conclusions about effectiveness. There were not that many controlled studies. Most of the studies were uncontrolled studies, no comparison group to be able to show whether the intervention worked better for this group than a group that didn't get that intervention. And so I think the lessons learned from this systematic review are as follows. It's not possible from this current corpus to scientifically conclude which interventions work to prevent Indigenous suicide. Only 4 studies included comparison and control groups with just one randomized controlled trial, and only 2 interventions appeared across multiple outcome studies, which means that there's limited replication. We also conducted another systematic review that's currently under review about the rationales of these suicide interventions to get a better sense for how tribal communities are adopting these approaches. Our research question is, what logics or rationales have structured interventions aimed at preventing suicidal behaviors among American Indian and Alaska Native populations. Again, we used really broad inclusion criteria to capture everything we could find, and we identified 32 studies about 24 distinct interventions published between 1976 and 2020 that were focused on various attributes and characteristics of these programs that we might be able to summarize. You can see a few of those there at the bottom of the slide about those attributes. What we wanted to do, though, was to try to classify these in some way. And so we drew on the CDC's prevention strategies that they already promote widely. And these are the 7 CDC prevention strategies. I've arranged them in hierarchical order from the most prevalent to be used in the interventions that Indian country had adopted. So promoting connectedness was undertaken, interventions that did that were undertaken by 15 communities, or interventions that created protective environments were done by 12 communities, interventions identified and supported people at risk by 12 communities. If you drop down closer to the bottom, though, interventions to lessen harms and prevent future risk, not so common, or interventions to strengthen economic supports, not so common. There were some trends that we drew out then from this analysis. First, most communities adopted mainstream suicide interventions as the backbone of their programs. Most communities also adapted these interventions to fit community needs and sensibilities, including things like collectivist self-orientations in Indian country, culture as treatment commitments, strengths-based approaches. Also, there was comparably less emphasis on a couple of key strategies: transforming healthcare services. For example, hiring more providers, improving depression treatment were not really that present, or community-wide policies like firearm control or regulating alcohol access were also not really appearing often in this body of literature. What was key was the adaptations that were made in these interventions for Indigenous orientations and commitments. And they were orientations and commitments reflecting sociocentric selfhood, collectivist identities that we find in our communities, an emphasis on shared suffering, historical trauma, and the resulting kind of anomie in psychosocial terms. There was really a preference for local or non-professional helpers that these interventions tended to emphasize. And there was an implementation of suicide prevention really as a form of decolonization. So these are the accommodations, the tailorings, the adaptations that really were necessary for these interventions to make sense for our communities. So take-home points. Indigenous communities both adopt and adapt mainstream suicide prevention strategies. The processes of intervention, adoption, and adaptation are responsive to community orientations and commitments. Rigorously designed scientific outcome studies are extremely rare, and the effectiveness of these adapted community interventions therefore remains an open scientific question. Let me turn now to some closing reflections on preventing Indigenous suicide. First of all, I want to just touch on 4 facets of Indigenous suicide prevention that I think come through the literature that I've tried to summarize today. Development of evidence-based practice requires scientific research on intervention outcomes. That's the logic and rationale of it. That's what it means. That's where it comes from. Robust intervention outcome research, though, is challenging and therefore rare in our communities. Promotion of formal evidence-based suicide prevention in our communities will therefore require both adoption and adaptation of mainstream interventions. On the positive note, our communities are already doing this, and you're going to see a lot of examples a little later today throughout the rest of the day of instances in which our communities are doing this. You'll hear the details and the ins and outs of it. Now, I was asked to sort of make recommendations. What should communities do? And I do feel, as a Native person, as most of you will understand, a little reluctant to tell people what to do, especially communities. So instead, I'm choosing to ask some questions that I think it would be helpful for us to answer for each of our respective communities to know how to move forward. So here are 4 questions concerning evidence-based suicide interventions for our communities to consider. First of all, how confident are we that mainstream evidence-based suicide interventions deserve special recognition and promotion in our communities? This is in some ways over against cultivating our own approaches, whether those approaches are based on traditional health practices or what have you. So how confident are we that we need to depend on, draw on, and replicate these somehow in our own communities? Second, what are the prospects for adopting and adapting additional mainstream evidence-based suicide interventions? For example, some of the better or most effective approaches are means restriction, and yet there wasn't much of that going on in the interventions in any country that have been published so far, or better depression treatment. So given the striking capacity and resource constraints in our communities, how realistic is it for us to adopt and adapt a wider range of evidence-based suicide interventions? Third, how can we design multi-level suicide intervention programs across providers, domains, and settings, despite the existing administrative challenges we have in many of our communities? And finally, what resources are available to us to develop more comprehensive suicide prevention services and to assess the impacts of those services? So this stuff takes resources, as we all know, and many of our communities are resource strapped. And yet, we need to not only implement these kinds of interventions, but we want to design, adopt, and adapt them while keeping track of outcomes. And so that takes resources and what resources are available for us to do the best we can to keep track of outcomes, not necessarily with all the scientific bells and whistles, but at least keep track with to whatever degree we can. I want to close today by first thanking for the invitation to come talk with you. And also just to let you know that I've written and thought a lot about Indigenous community mental health, including suicide. I try to make my publications available to people on my website for free download. Otherwise, they're behind paywalls and hard to access. So my website, gondowar.com, is where you can find a lot of this stuff for free, at least until I get in trouble and they make me put it down. Thank you so much for your time today.